This presentation reviews the 2013 Acta Neuropathologica paper by Edelbiaset and colleagues on genetically tested X-linked hydrocephalus. The focus is L1-CAM, meaning L1 cell adhesion molecule. Not only the mutations themselves, but the fetal neuropathology that helps recognize L1 syndrome, distinguish it from mimics, and identify L1-like cases where the molecular cause was still unknown. The clinical problem is that congenital hydrocephalus is genetically heterogeneous. In a prenatal or postmortem setting, clinicians may see severe ventriculomegaly, but that finding alone does not tell us which gene to test. The authors ask a practical question: which neuropathological features best predict L1 CAM-related disease, and what should we make of cases that look like L1 syndrome but have no L1 CAM mutation? L1 syndrome is an X-linked recessive disorder caused by mutations in L1 CAM at XQ28. It includes hydrocephalus due to stenosis of the aqueduct of Sylvius, abbreviated HSAS, mental retardation, aphasia, shuffling gait, and adducted thumb syndrome, abbreviated MASA, X-linked complicated hereditary spastic paraplegia type 1, abbreviated SPG1, and X-linked corpus callosum agenesis. The severe fetal presentation is only one end of that spectrum. The key teaching point is variability. The same gene, and sometimes even the same family, can produce fetal lethal hydrocephalus or a milder postnatal neurological phenotype. L1 CAM encodes a transmembrane cell adhesion molecule. Its protein structure includes immunoglobulin-like domains, fibronectin type 3-like domains, a transmembrane region, and a conserved cytoplasmic domain. Functionally, it participates in cell-cell adhesion, neuronal migration, neurid outgrowth, and axonal pathfinding. So when L1 CAM fails, the phenotype is not simply blocked cerebrospinal fluid or cerebrospinal fluid. It is a developmental disorder involving tracts, midline structures, ventricles, and motor pathways. The authors had three linked aims. First, they wanted to describe detailed fetal and newborn neuropathology in mutation-positive L1 CAM cases. Second, they wanted to measure the diagnostic value of 6 cardinal signs: male sex, hydrocephalus, adducted thumbs, aqueduct stenosis, corpus callosum anomalies, and corticospinal tract abnormalities. Third, they wanted to classify mutation-negative cases and decide which represented true mimics. Aqueductal atresia spectrum, or L1-like phenocopies. The cohort came from 32 French centers between 1996 and 2011. It included 138 cases, 134 fetuses, and 4 newborns, ranging from 14 weeks gestation to term. All had been referred for L1 CAM screening and underwent autopsy with standardized neuropathological review. Genetic testing sequenced the 28 coding exons and intron-exon junctions. The workflow yielded 57 deleterious mutations, 79 cases without an L1 CAM mutation, and 2 variants of uncertain significance that were excluded from later analysis. The mutation-positive group consisted of 57 male fetuses or newborns from 54 distinct families. There were 49 distinct mutations, and most were private mutations rather than recurrent hotspots. Mutation classes were distributed across missense, frameshift, splice, nonsense, and large rearrangement variants. Importantly, the fetal phenotype was relatively homogeneous despite this allelic heterogeneity. The authors could not define a reliable genotype-phenotype correlation by mutation type or protein location. In nearly every mutation-positive case, hydrocephalus was detected by routine ultrasound early in the second trimester. It could appear isolated or with corpus callosum agenesis. Adducted thumbs were detected antenatally in only a minority, even though they were common at autopsy. Most pregnancies were medically terminated, 4 newborns died soon after birth, and 1 fetus died in utero. The overall pattern was neurologic rather than a broad visceral or skeletal malformation syndrome. The mutation-positive phenotype was strikingly consistent. Hydrocephalus was present in all cases, adducted thumbs in about 88%, pyramidal or corticospinal tract agenesis or hypoplasia in about 98%, aqueduct stenosis in about 90%, and corpus callosum agenesis or hypoplasia in about 68%. But the lesson is not that any single sign is diagnostic. Hydrocephalus is extremely sensitive, but the diagnosis becomes more convincing when multiple midline and motor pathway signs cluster together. This figure is the visual core of the paper. The panels show adducted thumbs, sometimes with camptodactyly, severe hydrocephalus with corpus callosum agenesis, apparent thalamic apposition from collapse of the third ventricle, absence of a patent aqueduct, Probst bundles in callosal agenesis, and absent pyramidal tracts. Together, these images reframe L1 syndrome as more than aqueductal stenosis. It is a disorder of commissural and corticospinal tract development. The most informative anatomic axis is the combination of corpus callosum and corticospinal tract development. Among evaluable mutation-positive cases, the corpus callosum was abnormal in 43 of 44, and the corticospinal tracts were abnormal in 47 of 48. Pyramid agenesis or hypoplasia was frequent, and internal capsule abnormalities were also observed. This helps connect fetal pathology to the living phenotype. Corticospinal tract defects map well onto spasticity and the adducted thumb spectrum. Aqueductal stenosis remains important, but the histology matters. In L1 syndrome, the typical pattern is an isolated narrowed lumen without atresia forking or scattered ependymoline tubules. By contrast, the aqueductal atresia spectrum shows absent patent lumen replaced by small ependymal channels, often with rhomencephalosynapsis, mesencephalosynapsis, or diencephalosynapsis. This distinction prevents overcalling every severe hydrocephalus with aqueduct abnormality as L1 syndrome. The histology also reinforces what is common versus what is incidental. Cortical lamination was generally normal, and major migrational abnormalities were not a consistent feature. Rare findings included micropolygyria, pachygyria, tectal hamartoma, olivary heterotopia, dentate nuclear dysplasia, and cerebellar hypoplasia. For diagnostic purposes, though, the high-yield findings remain hydrocephalus, corpus callosum abnormality, aqueduct stenosis, and corticospinal tract abnormality. The 79 mutation-negative cases were not a single residual bucket. Neuropathological review separated them into 4 groups: 35 central nervous system, or CNS, malformation cases, 21 cases in the aqueductal atresia spectrum, 16 L1-like phenocopes, and 7 polymalformative syndromes. This classification is one of the paper's major contributions. It shows that a negative L1 CAM result can still contain recognizable biology, including a group that strongly suggests other, possibly autosomal recessive, hydrocephalus genes. The diagnostic performance data make the screening strategy more precise. Hydrocephalus was perfectly sensitive in this series but very nonspecific. Corpus callosum abnormality was also highly sensitive but not very specific. Corticospinal tract abnormality was the best balanced single neuropathological sign, with about 98% sensitivity and about 62% specificity. Adducted thumbs and aqueduct stenosis were less universal, but they added important specificity. Positive predictive value, or PPV, tells the same story in a more practical way. Hydrocephalus alone had the lowest PPV, around 44%. Corpus callosum abnormality was similar, around 47%. Corticospinal tract abnormality rose to about 59% and aqueduct stenosis to about 61%. The strongest single enrichment feature was adducted thumbs, with a PPV of about 74%. So the most useful approach is pattern recognition, not ventriculomegaly alone. The authors also push the mechanism beyond a purely obstructive model. L1 CAM dysfunction affects adhesion, axon guidance, and fasciculation. That can produce callosal and corticospinal tract agenesis or hypoplasia, while also altering ventricular development and midline anatomy. Aqueduct narrowing may be present, but in some cases it may be secondary to massive ventricular deformation. Animal models also suggest that genetic modifiers can influence the severity of hydrocephalus. For differential diagnosis, the main message is to avoid treating all fetal hydrocephalus as equivalent. Aqueductal atresia forking is the key histologic mimic and should be separated from L1-associated stenosis. Fetal alcohol syndrome can overlap through hydrocephalus and callosal defects, but maternal history and craniofacial dysmorphism are decisive. Other groups include tubulinopathy-like malformations, collagen type 4 alpha 1, or COL4A1-like porencephaly post-hemorrhagic changes, vertebral, anal, cardiac, tracheoesophageal, renal, and limb anomalies with hydrocephalus, abbreviated Vactor-Lach, Meckel, or Joubert spectrum, and the L1-like phenocopy group. As a journal club paper, the strengths are clear. This is a large fetal and newborn series for a rare disorder, with centralized L1 CAM testing and systematic neuropathological review. It also directly compares mutation-positive and mutation-negative cases. The limitations are also important. The design is retrospective. The referral pathway enriches for severe prenatal phenotypes. Some signs were not evaluable because of autolysis or severe hydrocephalus, and the L1-like group did not yet have definitive molecular diagnoses. The take-home message is that L1-CAM-mutated fetal hydrocephalus has a recognizable neuropathological signature. Hydrocephalus is sensitive but nonspecific. Adducted thumbs, aqueduct stenosis, and corticospinal tract abnormalities enrich for mutation. Corticospinal tract abnormality is the best overall single discriminator. Aqueductal atresia forking is a critical mimic. And when hydrocephalus is accompanied by at least 3 additional cardinal signs, the authors recommend L1-CAM screening. The L1-like negative cases point toward additional genetic causes still to be defined.